Good evening, everyone. Welcome to our Medical Countermeasures 101 training um, for Medical Reserve Corps members, not just the University of Minnesota, but other MRCs across the state. Welcome to our training. I'm Courtney Weddernock. I am the MRC manager for the University of Minnesota Medical Reserve Corps, and then I also teach a class on public health emergency preparedness and response in the School of Public Health. Um, we are recording this. I think all of you heard that, so hopefully that is okay. We're going to put it on our YouTube channel. We like to just record our webinars now so that we can share them with new people as they come along, or sometimes even like just in time before a training or a real incident. We'll have people go back and watch a certain webinar. So that's why we're recording it. Questions, put in the Q&A or the chat. Rachel and I will be kind of trying to monitor that as we go. And then we'll have time at the end for questions that don't get answered during Rachel's presentation. And then I don't think there's anything in here that could be triggering, but just in case, I always like to just give people a trigger warning if there's anything that makes you feel uncomfortable or whatever. Please just leave the meeting, take care of yourself, whatever you need to do. Rachel, I'm going to turn it over to you.
Great. Hi, so I'm Rachel Schulman. I am the Vaccine Response Team Co-Lead for the UMN Medical Reserve Corps, and I'm also a volunteer with the City of Minneapolis Health Department volunteer group. So I am here to talk to you today about medical countermeasures, which we also call MCM. This will be a pretty high-level presentation. There'll be a little bit of stuff that's specific to the University of Minnesota, but most of it will be more broadly applicable. So I think even those of you who are here from Minneapolis should get plenty out of it. And if you have any questions about anything that I talk about and how it might apply, from the Minneapolis side rather than the university side, I'm happy to talk about that too. So just a little bit about my background. So I got involved in emergency preparedness back in 2012 when I was a student at Johns Hopkins. While I was there, I worked for the City of Emergency Management in Baltimore, or City Emergency Management Agency in Baltimore. Then I went to the National Association of County and City Health Officials, where I worked on public health preparedness issues sort of nationally. I also helped local health departments across the country with their emergency planning processes, and got a lot of expertise around that. And then brought that to my job at the Minnesota Department of Health, where I was their medical countermeasures planner for 5 years. So we did a lot of work on basically building out plans for what I'm going to talk about today. And then I stayed there through 2021 when I moved over to the university, where I now manage the Center for Public Health Systems in the Division of Health Policy and Management in the School of Public Health. And then shortly after joining, I also got an email about joining the MRC, and I thought that would be fun. So here I am. All right. So just some background on some terminology, because there's acronyms and there's other sort of specific terms that end up getting thrown around, and I want to make sure that we define our terms before we get too deep into it. So a lot of this conversation is going to focus on prophylaxis. And so I just want to make sure that everyone understands what that term means. So in this context, we're talking about a medical countermeasure, which could be like a pill or a vaccine, some kind of medical intervention that you give to a person to prevent them from becoming sick, or to kind of lessen the severity of a sickness that they are likely to come down with. So you can sometimes give it if it's fully preventive, the person has not even been exposed, but you're going to give them this prophylaxis, it'll keep them from getting sick. For sometimes, maybe that person has been exposed, but getting the prophylaxis will um, help reduce their symptoms, or maybe even just reduce them to the point that they don't even have any. Um, so it's an important tool that we have in public health preparedness when we're talking about like different kinds of diseases or outbreaks that might happen in a population. So now we'll define medical countermeasures. So in this context, we're talking about prophylaxis that we're administering to a large group of people in a short period of time. So this is something that will this is a tool that is used when like a population is very suddenly put at risk for serious illness or death. So usually the stakes are pretty high in a situation where we would roll this out. Um, and usually it's something that's come on pretty suddenly, and it's affecting a lot of people. So affecting people in a way that would make overwhelm the healthcare system as it is currently structured. Like if a small group of people were affected by something, they could just go to their healthcare provider, they could go to a hospital. But if so many people are impacted that those resources would become overwhelmed, that's when we start to talk about a response like this. So again, it could be a pill or a vaccine. It could be regarding a naturally occurring thing like a pandemic. It could be something man-made that was released. It could be, and then it could be, bioterrorism, like a purposeful release. It could be something accidental. So there's a number of different circumstances under which something like this could happen. So there's a couple of reasons that we plan for this. And some of those things have happened before, and you may even remember them. So really, a lot of medical countermeasure planning in the United States got started like post 9/11, after the anthrax scares. There was a lot of focus on like rapidly detecting pathogens that have been released and how you'd respond quickly to something like that, particularly bioterrorism. Um, in the field, though, there's also always been an importance on pandemic illnesses, and in particular pandemic flu. That's something that obviously has happened many times in the past, and so is always a risk that it'll happen again in the future. So public health folks are always kind of thinking about what happens if there's like a new flu strain that results in a global pandemic. Obviously, we've lived through other kinds of illnesses that can also become pandemics. And then it's also just useful to plan for medical countermeasures for things that you never would have even imagined, right? So like we did a lot of planning at the state for anthrax and for pandemic flu. We did not plan specifically for COVID at all, wasn't on our radar, but the work you do to think through how you would respond to those events really is critical for when this new unanticipated event arises. And then you have some frameworks to pull from, some common understandings and some plans that can be adapted to whatever it is that that is occurring. So here's an example where we kind of highlight the difference between like a regular healthcare event versus like a medical countermeasures need. So for seasonal flu, there is a relatively low risk to an individual that you're going to get very sick, although it does exist, right? So we encourage people to get vaccinated, but it's kind of over a longer period of time. We do like campaigns about seasonal flu vaccine, like, for all like throughout the fall. And there isn't that sort of urgency, and people can just go to their normal healthcare providers. You may stand up some clinics to make it a little easier for them to go at work or something like that. But the stakes are quite a bit lower. Versus pandemic flu vaccine, the overall risk to an individual is like extremely high. And so there's a very strong encouragement or maybe even a requirement to get vaccinated and also to do so quickly. So you have both the short timeline and the large population that are making it important to kind of look at this a different way. Another example here about like how medical countermeasures would be implemented is if we're talking about like a bioterrorism event. So Um, there's, if there were an anthrax attack, um, which is like a common scenario that we plan for, is sort of like a just to create a planning framework for ourselves in public health preparedness. Um, that's an illness where it could impact a lot of people very quickly, but prophylaxis can have, if administered also quickly, can have a real meaningful impact on the number of people affected. It can really lower the risk of illness or death. So we think about there's like a release in like a city or at a large event. If we take the time to figure out who is exposed, like wait until they develop symptoms or send each of these people to their individual, tell them to make an appointment with their doctors, by the time all of that happens, those folks will be shown, they'll be so far down the road to being sick that prophylaxis won't help them anymore. So this is where we kind of take the approach where, and we'll talk a little more about the balance of risks and harms later, but like you're taking this approach where maybe you will overtreat, maybe you will scoop up people who weren't exposed, who weren't going to get sick, but by sort of immediately dispensing prophylaxis to all the people who you think are at risk overall on a population level, we have the chance to really save lives. So here's where we talk, like when it comes to medical countermeasures, this is the balancing the risks versus the potential harms is like at the core of the situation always. You have this real serious health threat that's facing a population, serious illness, maybe even death. But there's also this risk of potential harm from prophylaxis. These are medical interventions. People do get side effects from taking an antibiotic. You may end up giving some antibiotics to someone who was not meaningfully exposed. And if they had a side effect, then they're technically worse off than they would have been. And so what you kind of have to do in this situation is come up with a medical protocol that basically strikes a balance, where you're not putting people too much at risk by what you're treating them for, but also you're prioritizing the fact that if they don't get treated, they might die. And it's can be difficult for people to wrap their heads around, giving an intervention, like giving a pill or giving a vaccine that may cause a harm. That really is difficult for folks, even though what they're doing overall really drastically reduces the risk of harm. So it's just sort of like a psychological challenge sometimes among folks who are either working in pods or coming to pods. Pods being a term I will define a little bit later, but basically, so yeah, I think the goal of this is engaging medical expertise to kind of strike that balance where you're trying to minimize those side effects and maximizing the benefit, still treating people quickly, because if you take too long, you're not going to get to all of them. More of them will get sick, but making the screening good enough that you're not causing undue harm. So this is a slide kind of demonstrating how a medical countermeasure response would get started. So there would be some kind of alert, either healthcare would pick up on something going on, or law enforcement if it was a bioterrorism event, or both. And then at the state level, there would be some kind of declaration of an emergency that something was happening. And then that would then local health department measures. So everything, like all the different levels of government are kind of working together, but ultimately the local government is the one that's kind of like interacting directly usually. So local health departments will have two plans for how they dispense medical countermeasures usually. So there's a point of dispensing, POD. An open one serves the general public directly. So all health departments are supposed to have plans for how they would do this. And like they usually have agreements in place with different facilities that they could use for this sort of thing. There's also closed pods, which serve particular organizations or groups and just focus on serving those. And there's a couple reasons for that. I think those are on the next slide. Yes. So the reason you have closed pods is you're just kind of like enlisting like well-functioning organizations to kind of help take the pressure off the open pod. So if you are a small health department and you're opening your doors to everyone in your county and they're, any family that's visiting, anyone who happens to be in town, that's like a very overwhelming effort. And so a closed pod is a way of having certain agreements in place in advance where you say like this large employer has already thought through with you how to dispense pills to like their employees and their families. And they already have a communications plan. So they can take this whole group of people off your plate. So you can use that. So that's like the University of Minnesota, it's a closed pod for that reason. It's also something that's used for the people who are critical to the response. So like for healthcare professionals or law enforcement, you want to make sure they get vaccinated or they get pills or whatever right away because you need them healthy to help with your response. And so you plan that as a small closed pod so that you sort of get that done out of the way separately. And then those people are available to help the general public. So University of Minnesota operates as a closed pod. So in most scenarios. So in the scenario we just spoke about, where like there's an emergency declaration coming down from the state level, we would plan to dispense or vaccinate just those who are associated with the university, probably also their families. And since we serve a large population, we would probably work directly from the state. So like the state would, if they get things from the federal government, or if they purchase stuff, that would probably come directly to us rather than through the city of Minneapolis or Hennepin County, but just because it's more efficient. Whereas folks over here from the city of Minneapolis, they would probably also get their stuff down through the state. So in like a separate stream. Now there are like some limited scenarios in which the University of Minnesota on its own might be like, hey, we need to open a pod, like without the state kind of telling us to. An example might be like a meningitis outbreak that poses a risk to UMN students, where we wanted to get a lot of students vaccinated very quickly. There aren't so many of those scenarios, but it is possible. And that is a thing that we could do. It's not that we're not, like, it's a tool that's at our disposal if we wanted to. So as I kind of talked about before with like the medical protocols and the balancing of risks and harms, that's not something that we at the university need to worry about coming up with on our own. So that's something the state is going to have their own medical protocols. They have a medical director. They're going to come up with all of that direction in terms of telling you not only like this is this is the pill or this is the vaccine, but they're also going to tell you how to screen for it and like what conditions might be exclusionary and things like that. So in terms of like that medical decision making in most cases will be out of our hands, which is good. Like we want consistency, we want people who know what they're doing making those kinds of decisions. Where UMN will have control is sort of like in operationalizing that. So in terms of like how we set up a space, how we drive people through it, all of that is kind of up to like how we communicate, all of that is up to us. So we can plan in advance for like how we want to set up our site, because kind of no matter what it is, I mean, it's like a little bit different for pills versus a vaccine, but in general, as we'll see, like the different stations that you would go through and the different steps are pretty similar. So we can kind of think about that even without knowing what the actual medical protocol is. So here's an example pod layout. So you start with like an entry and greeting area. This is like an initial location where people come in, and they'll get some kind of intake form where they'll fill out some medical information. Usually there may also be somebody outside, like directing traffic, helping people park, stuff like that. After then people go into triage and screening. So these forms, again, like these are often the content of the forms and what people need to be screened will usually be provided by the state. So staff will review the forms, kind of and see, is this person good to move ahead to the sort of regular dispensing area? Like, are they just getting the thing that most people are getting, or do they have some kind of medical issue where we really want them to talk to like an actual doctor about their specific situation? And so you kind of divide people into these, like the express lane and then the lane where they might need like a specific medical consult. And then once you get your drug, or if you're in the medical consult, like maybe you get a prescription to go somewhere else to pick up a different drug, then you kind of move on to the next stage of the pod. If you've gotten a shot or if you've taken a pill, you may need to kind of like sit and be observed for a while, make sure you don't have any side effects, especially with vaccines. Like that's something that is often the case with the vaccine where the doctor wants to make sure that you don't have an adverse reaction. So we have people kind of monitoring that. And then they leave. So when you're thinking about setting up a site like this, ideal sites are usually like these big, large open spaces, like a gym or a cafeteria. Fortunately, the University of Minnesota has a bunch of these. And you want people kind of like coming in one way, going through the layout, and then leaving and not crossing each other, using different entrances and exits, that kind of thing. And then there's usually also a security component. And depending on the drugs, you're going to have to make there may be certain storage protocols around like temperature and things like that. So that's just sort of to give an idea about like the different components of the pod. And so
Rachel, can
now
I
when you're
make a quick comment about that? Can
yeah.
you go back? Can you go back one slide?
Mhm.
So Rachel talked about people that might need a little bit of additional medical evaluation and how they're sort of veered into a separate lane. I just also want to mention that all health departments should have plans to also accommodate people that may have, we call them access and functional needs. If they have mobility issues that are hard to get through the pod, we would have a separate way that we would handle that if they're not a native English speaker and they need an interpreter, if they're a child with sensory issues, and this is going to be a loud, crazy place. There's other options that the health departments have thought through ahead of time to be able to make sure that all of the people that need the vaccine or pills are able to get it at an open pod.
Yeah, that's a great point. Thank you. I should have mentioned that. And usually that'll all happen at the entry and greeting area. Like that's where you kind of assess, like, does this person need additional support in any particular way? And sort of get them whatever it is to help them move through the pod. I'll also say that like each of these roles will, like, as UMN or the city of Minneapolis or whoever is planning for these, bills out what they want their pod to look like, they'll put together what's called a job action sheet, which will spell out the roles and responsibilities of like what that person in each of these roles is going to do. So when you are sort of slotted into a position like this, there is like a preset sort of training that will go through like the different things that you're supposed to be enacting in your piece. So we've talked a bunch about screening, and this is just like a really high level example of a screening algorithm. these will probably be a little more involved, again, because of that balancing of risks and harms. But this is just sort of like a general sense. So like if you have a patient that comes into triage, um, first you might ask them if they have symptoms and kind of like if they're already sick, like you want to address that. Um, and then you might, if they're not symptomatic, then you might ask them about like specific medical conditions or allergies that might impact which medication they get. Like a good example would be for anthrax. There are two major antibiotics that they usually consider for that prophylaxis, doxycycline and ciprofloxacin. And so depending on your answers to these questions, that flow diagram might take you to a different answer of like which antibiotic you should get. So, or that flow diagram that you go through, answering yes or no to these different questions might take you to what this person needs to go see a medical consult. So, a person in this role, sometimes these things are computerized, sometimes not. But if they're not, you get kind of like a flow chart, sort of like this, where you see what they answer to different questions and kind of go yes, no through the flow chart until you get to like an answer of like, they get this antibiotic or this one, or they need to go talk to a medical professional. So once it's determined what they do, those who can go to the express dispensing and get the pills that we have in stock will do that. And then, if observation is needed, they'll have observation and then they'll leave. So here are some of the roles that kind of map onto that flow chart that you might have as a volunteer. So logistics and setup would be one, like when you think about what you would need to kind of direct people through a large space. There'll be you need tables and chairs in different areas. You'll need to like set up queuing lines in a way that makes sense for the space. You'll need rest areas, like you'll need to pre-stage a lot of things. And so I know University of Minnesota has like supplies like to do this, and a lot of health departments do as well, or they know where they're going to get them. You may have someone outside doing traffic direction if you're expecting a lot of people to kind of be descending down this site at once. You'll have greeters, like we talked about, where they'll welcome and direct people, and find out kind of like what needs they might have. If they have like a mobility issue, or they need a translator, something like that, they would be referred over here to the language access support folks that we would have in place. You might be a screener, kind of either going through that electronic program or going through that manual flow chart based on the answers to their screening questions to figure out which prophylaxis to give them. You'll also have doctors on site or like other medical professionals who have the ability to prescribe a medication. And those folks will help with people with like some more complex medical conditions. You may be a dispenser, or if you are a licensed medical professional, you might be a vaccinator. There are no plans to take, like, if you are not already someone who's licensed and able to give a vaccine, you would not be trained to do that just in time. Sometimes legally, like the state can expand who is allowed to give certain kinds of vaccinations, but it would not go to like someone who is not already some kind of medical professional. So like we might have a standard volunteer like myself, like dispense a medication, take out a container of pills and like hand it to someone, but you don't have to worry about ever needing to give someone a shot if that's not already a thing you know how to do. Then you'll have people monitoring, especially monitoring for folks who may have just gotten a vaccine or taken a pill, making sure they have no side effects. So again, like these are just sort of like high level roles, but any time you volunteered for one of these, you would get trained and you would get like a job action sheet of like written instructions of like what you were actually supposed to do specific to that situation. So that is really all I have. I don't see any questions in the chat. I don't, is there a Q&A, Courtney? Were there
There,
other
yeah,
questions?
there's a Q&A, but there are no questions in it. Um, so if
Does
you
anyone
have
have a
questions,
question?
yeah, you can either put it in the chat or raise your hand. Um, yeah,
Yeah, so
Kathy's
Kathy,
saying,
that's a great example of like during COVID, they kind of expanded the ability of like the rules of who could give vaccines to include veterinarians, and that helped you know, the ability to give more COVID shots, but like it's not like veterinarians have never given vaccines before. So that's like a perfect example. Would this process ever be used if there was a measles outbreak in Minnesota? Um, I, in a possible future where fewer people were already vaccinated, I think possibly, but at this point, there are, the majority of people are still vaccinated. So I think like standing up something this extreme probably wouldn't be needed, but you would probably have like you might have pop-up clinics or like additional like sort of individual one-off events or like um organized events of increasing frequency to kind of try to get people who aren't vaccinated to come in. But I don't think this would be needed for
no,
measles.
and just kind of a comment on real life experience when we had a measles outbreak in Hennepin County in 2017. Um, we ended up kind of doing a few different models, but we did end up sending nurses out to individual homes to offer them vaccine if we knew that they weren't vaccinated, especially if they were in what we called exclusion at that time. So, if you've heard quarantine, um, or isolation, if they were, had to stay home because they had been exposed and had to have potential to develop the illness because they're susceptible. We don't want them coming to um, a crowded area. So we went to them. Um, Rachel, one question, and I see a few popping up in the chat too, but I thought about this early on. Um, is immune globulin considered a medical countermeasure? Do you know?
So I think it is, but from what I remember, it's like tricky because there isn't really the infrastructure to give it like on a large scale.
Yeah.
So
And it's a
like
tight window. It's like a tight window that you can give it, at least for
yeah,
measles.
so like we kind of tried to do some planning for that, and I think maybe in certain circumstances you would be able to do that, but like you wouldn't be able to do it in like a pod setup with like, mass administration of it.
Yeah.
So,
Almost like a
but like
mini
for
pod.
someone who couldn't like, for like maybe like a medical consult might ask for that, you might be able to give it to like a limited number of people.
Yeah, and that we also did that during the measles outbreak in Hennepin in 2017. We most of the time, by the time we found out about an outbreak, it was the timeline was too far past to be able to offer immune globulin or vaccine. Um, but there were a couple times where there was like a new school exposed, and if we knew that right away, we were able to do immune globulin clinic, and we did one of those. um, and Rachel touched on this a little bit, but there's different approaches or different ways that you might need to staff your pod based on the population. So if it's a lot of kids, you might need to have different types of flow, or you might be asking them different questions, or something like that. And so it reminded me of that situation when we did catch a new site in time and were able to do immune globulin, but it was a very small scale. It was a mini pod at a school. It was like a
Um,
closed pod. It was like a closed
yeah.
pod, I would say. Yeah.
I don't think paramedics were vaccinators during COVID, were they? Or am I don't quite remember.
I'm not sure.
I think maybe not, but like I think that's the sort of thing where like that's sort of up to the judgment of the governor and like his the medical director and like sort of what the level of emergency is and how much they feel like they need to expand the um the scope of who can vaccinate for the event.
Mhm.
Um, so I don't, in terms of how this process is changing due to like anti-vaccine and anti-medication, I mean, like when we talk about this, it's generally predicated on people coming in of their own free will.
Mhm.
Um, and I think we would do our best to try to communicate the risk that people are at and the value of coming in quickly. But ultimately, it's going to be their choice. So I think a lot of communication has changed and a lot of like community engagement work is changing in terms of how to try to reach folks in like, day to day. And I think some of those lessons would probably be used in this situation, in like a medical countermeasure situation as well. But I don't know that it changes like the logistics of how we would actually do the whole administration of it. Courtney, do you have additional thoughts on that?
No, I agree.
If you're not, so I would say if you know, there are going to be plenty of volunteer roles at any given pod, and so if you are not comfortable with like if you're like there are children coming in and I don't feel comfortable deciding what medication they give to give them, or I don't, if there's anything you're not comfortable with, I'm sure there's a role for you that you could do something else. I think it's just we would never want anyone to be in a position where they're not comfortable doing what they're assigned. And so you could like I think you could just make that clear and someone, you could be moved around or something. There would be plenty for people to do. um
Rachel, Dr. Grant has a question. What happens if slash when large numbers of people actually become seriously ill? Is someone doing planning for this eventuality? I'll let you take that first and then.
um yeah, so that's called medical surge planning. And that's something that healthcare facilities work on. And they have they also work with public health on that, but like that like a separate undertaking. But yes,
Mhm.
there is medical surge planning. There's something called crisis standards of care that people work on, which is sort of like how you do healthcare like under those circumstances when maybe resources are constrained, and you have a large number of people that need to be treated. So it is something that is worked on. I think you're less likely to be called upon to help with that as like a volunteer. That's something more that like those in the healthcare system are thinking about and working on.
Yeah, although we do, have the capability to deploy Medical Reserve Corps volunteers to hospitals or healthcare organizations, if it was really to the point that we would need to do that, and it would be very probably narrow focus in what the MRC volunteers would be able to do in hospitals. And this can go down a whole rabbit hole, so I'm not going to talk about it too much, but um, we did have a situation once where we were asked to, this was when I was at Hennepin County, asked to help Hennepin County Medical Center with something, and I don't remember the details, but we ended up, as we kind of talked about it a little bit more, we ended up realizing that we couldn't provide any volunteers there because of some of the policies that HCMC had for people that were, working at their organization. And so it can get really complicated depending on the situation, but the good thing is that between healthcare, public health, EMS, emergency management, other disciplines like that, we all do planning together so that we're able to, kind of operate with that common operating picture, and we all sort of have that standard baseline, how we would respond in our different discipline and how we could support the other disciplines if necessary.
I see
Uh,
another question here on the application of NIMS and ICS. So ICS stands for Incident Command System, and that's really like a whole other training or a series of trainings. But I can say in just sort of like a very high level way, like the idea or a couple of the ideas behind incident command system, they're like it's a way of structuring roles and in a response, like in sort of like a pyramid way, so that you have people only kind of reporting to one person, and that person has a very specific and manageable span of control under them. Um, and that way, and so it keeps communication flowing along very particular lines and keeps decision making flowing in very particular ways that sort of keep everything organized. And so I different organizations implement it differently. Um, but I can say that like I think the way in which it might apply to something like this at the U would be like if you were in a role, like let's say you were a screener, there would be a couple of screeners, say like up to seven is like the span of control that you're supposed to have in ICS. And then there would be like one person, probably a like who would be the screening supervisor. And so if you had any issues as a screener, rather than just like, you wouldn't go talk to a dispenser, or you wouldn't go just sort of flag down whoever you saw. If you had an issue, you would go to your supervisor, and that supervisor, if they couldn't solve it, would kind of take it up the chain to maybe like the site manager or something like that. And so and that would all be detailed in your job action sheet, like where you are in the structure and how you communicate. But that's meant to make sure that like the person at the top in control always knows what's going on, and sort of like uh keep everyone like organized and communicating like efficiently. Um, but it really is like a whole rabbit hole. There's um and I don't know, Courtney, if you have thoughts, like are there more like trainings coming up on those topics if folks are interested?
Yeah, if you're a University of Minnesota MRC member, you have either already taken an online NIMS ICS course or you will be taking one this year as kind of our standard, um, minimum standard training along with psychological first aid. And I believe that most other MRC units in the state have also adopted the NIMS ICS and psychological first aid, along with two other new orientation modules as kind of their minimum standard for all of their volunteers. So if you're an MRC member or volunteer, I would ask your MRC lead in your county or city that question on how they want to kind of train you a little bit more on ICS, but there's lots of resources out there. We have a really good one at the university, and that's what all of the MRC units in the state are using.
Any other questions or anything in the Q&A? Or if anyone wants, like, you could just ask a question verbally if you would like.
Oh, okay. Um, any final thoughts, Rachel? Oh, hold on. Oh, Becca, we all have like these standard four trainings that all MRCs in the state have to do. So it's NIMS and ICS, psychological first aid, And then there's two new orientation videos. One is kind of like a just a basic MRC orientation. Actually, I'll pull the link and put it in the chat for those who want to see it. Um, and then there is uh, MRC 101, we called it, and it's more of like what to expect in a deployment. How do you do personal and family preparedness, that kind of a thing. So there you go.
Great. Well,
Um,
thanks
oh, sorry.
everyone for coming. I hope this gave you just a better sense of like, I feel like this is sort of like an add-on if you're like thinking about, um, what to expect in a deployment. This is sort of like what to expect in a medical countermeasures deployment. So, I know it didn't go super specifically into what, exactly is like on a given job action sheet or anything like that, but I think it hopefully gave you a general sense of like what a medical countermeasure deployment might look like and what it might, under what circumstances it might happen. So, if you have any other questions, feel free to email me. My email is on the screen here, or Courtney.
Mhm.
Um, I'd be happy to talk to you more.
Yep. And then just a quick mention of some next steps. Rachel kind of did a good segue. A couple of us in the metro public health departments are working on what we're calling sort of a pod essentials training. It was developed by CDC a few years ago, and we're continuing to kind of like get it to the bare minimum so that people have the ability to take it and it's not like an 8-hour day. So that's called Pod Essentials, and you'll probably start seeing information about those trainings or that training, or we don't know if we can make it into one in the fall. So your MRC coordinator at your jurisdiction will be sending out more information about that. And that's where we'll get into a little bit more detail about, looking at job action sheets, looking at some screening forms, that kind of a thing. So more job specific or role specific training. All right. Thank you so much, Rachel.
Thank you all for coming. Have a great evening.
Thank you.
Bye.